Reproducibility and reversibility are two really key concepts in medicine, and I bring them up with patients to demonstrate kind of what we're talking about in terms of their particular disorder, but we can also apply them to the whole, of course. Reproducibility has two main facets, one being, does the treatment reproduce its effectiveness among a cohort of people? Meaning, does it do it for patient A, B, C, and so on? Do we see that it stands the test of time, so to speak? And it's also reproducible when it's between sessions, or from session 1 or visit 1 to 2 to 3. In the case of a lumbar derangement that's mechanical, that responds to lumbar extension, for example, is reproducible if you get better motion, better symptoms when you do extensions in the clinic, and also when you do them at home, and when you do them again in the clinic. So that reproducibility is something that I'm looking for in terms of treatment thought processes. If it's not continuing to reproduce the same results, it's likely we need to change the treatment approach or look at some other variety of testing. Reversibility, I think, is actually more potent clinically. Reversibility is not something we really think about in orthopedics, I'm afraid. It's hard to reverse a tendinopathy quickly. You can reverse a bone fracture with instrumentation, and then you could take that instrumentation out and see if that treatment effect was due to reversing the fracture. Commonly, we also think of muscle strains, ligament sprains, tears and labrums. They're not really reversible in that they're going to heal with either an environment for healing over time or with surgical interventions, but reproducibility and reversibility are both apropos when it comes to mechanical joint derangements. By using repeated movement testing, I find that most orthopedic disorders are mechanical joint derangements, which most clinicians would disagree with. But because I can see the observable reproducibility and reversibility in the clinic, I gain credence I gain the ability to really understand that this concept of a joint derangement is verifiable. So for reversibility, I don't typically try to reverse the effects of something that's therapeutically successful in the clinic. But for those patients who are curious, I tell them, look, let's take a knee extension derangement. So it's a knee joint derangement. That's what I've diagnosed it as. It's a mechanical problem with the knee joint not moving well. And we do some extension and strength deficits return to normal, mobility improves, symptoms improve. Well, if extension is the directional preference, is the movement that reverses the disorder when done repeatedly, then for most, if not almost all patients, doing knee flexion should reverse those gains. So if we do 30 extensions of the knee and make gains, I could have the patient do 30 flexions and try to reverse those gains. Diagnostically, it's helpful to do because sometimes we're just questioning, could we move the knee any sort of way and get that beneficial therapeutic warm-up effect? Meaning you could move it any way you want, it's going to get better. And that's for those patients who I think need general movement. And those patients typically aren't presenting to orthopedic clinics because they've figured out that, just starting to walk more or do some movements generally help the problem. But for the patient who has a derangement as a specific diagnosis versus someone who just needs to move more, then the opposite motion, or at least a different motion, maybe knee extension with tibial rotation, should, in most cases, reverse those gains. So for patients who don't kind of believe what I'm saying, I'll say, okay, let's do the opposite movement and see if it is a warm-up effect, or let's see if there's something to this. It's really important, I think, when it comes to, for example, spine derangements and posture. Because if I'm trying to get a patient on board by showing that extension is therapeutic, I can have them flex and slouch sitting for 5 minutes and see if we reverse those gains, because I want them to see that one-to-one. I'm not using this reversibility as something that's trying to, really make my point and make the patient kind of know that I'm right, because sometimes we do need to look for reversibility to gain more credibility with the diagnosis. But If you have a shoulder joint derangement and it responds to extension, I should probably be able to make you worse with lots of shoulder flexion. If you have a hip joint derangement that gets better with internal rotation, I can probably get you worse with a lot of external rotation. So if I can't, maybe I'll look at hip extension, for example. But if I can't make it worse at all, and everything seems to make it a little bit better, then that's a different diagnosis. But think about reproducibility and reversibility, especially when it comes to mechanical joint derangements, because if you're just trying things at home, it's fun to see, oh, I move my shoulder this way, my strength gets better, my mobility gets better, the pain abates, and then I move my shoulder this way and woof, that strength goes back to being weak, the mobility gets obstructed again, the symptoms return. These two facets of medicine can be essential to understanding if the treatment that you're performing is actually successful.